Leaders of nations, public health officials, and global institutions, history will not judge you by your speeches, conferences, or promises, but by what you failed to prevent when the warning was already clear. People protest when jobs vanish, salaries fall, industries collapse, or politics fails them, yet almost no one is preparing for the silent crisis that can take away their health, family, dignity, and even their lives. Antimicrobial resistance and the spread of infections will not respect status, wealth, position, or power. This is not fear-mongering, it is biological reality. When those entrusted with responsibility ignore preventable suffering, they do not stand above the danger, they stand directly in its path. Dharma is not ritual, it is the duty to protect life before disaster strikes. Enemies will not destroy a society that forgets this truth, but through the silence of those who saw the danger, understood the warning, and still chose comfort, career, and reputation over the lives of other human beings. The epidemic unfolding in the Democratic Republic of Congo, driven by the Bundibugyo strain of Ebola, highlights a critical crisis in our global health defenses. Meanwhile, in Kerala, India, a severe Shigella outbreak continues to hospitalize children, exposing the devastating impact of entrenched vulnerabilities. These pathogens operate through entirely different biological mechanisms. Ebola as a hemorrhagic viral fever spread via bodily fluids, and Shigella as a bacterial infection causing widespread diarrhea, yet both outbreaks share a common failure: our public health system's inability to contain them effectively. This failure is not due solely to biological factors, still it arises from systemic flaws, delayed symptom recognition, missed contact tracing, and sluggish reporting that create structural blind spots that pathogens easily exploit. They outmaneuver our defenses not by biological weakness, but through systemic gaps that allow outbreaks to grow unchecked. To prevent future disasters, we must understand how contagious diseases spread beyond local containment and develop into epidemics. Every outbreak begins with a single unrecognized carrier, what we call zero, who unknowingly starts a relentless chain reaction. From this household, the disease quickly spreads. 3 family members, then 10 clinic visitors, then 100 community members, all before official data even detects the outbreak. The troubling truth is that by the time our health authorities issue alerts based on clinical diagnoses, the pathogen has already achieved exponential growth through complex networks. Improving our early warning systems and closing these structural gaps is essential. Only then can we regain control over infectious threats and protect vulnerable groups before it's too late. Between the first symptom at home and the first clinical diagnosis lies an invisible chain of contact that bridges the preclinical gap. This chain relies on human vectors operating completely below the radar of surveillance, asymptomatic family caregivers, local transport drivers, and passing community contacts, all active transmission mechanisms. These individuals contact fomites, physical objects such as bed sheets, sample containers, and surfaces of shared transit vehicles that carry the disease from one place to another. Standard infection prevention measures struggle to break this chain because they are designed for known threats rather than unrecognized carriers moving freely through a community. Even in professional settings, manual hygiene has strict limitations. The Department of Health and Human Services states that hand washing is a backup measure to be used if a dangerous organism is already on a healthcare worker's hands. Containment has already failed in clinical environments where surface contamination acts as a constant reservoir. Routine cleaning struggles to keep up with the continuous shedding of multi-drug-resistant organisms onto bed rails and equipment. Relying solely on manual hygiene without identifying and isolating the source at the field level simply treats the symptoms rather than addressing the root cause of transmission. There remains a widespread misconception that medical facilities act as containment zones. In reality, we confront the healthcare amplification paradox. Consider the physical movement of a symptomatic patient. They leave home, board public transport, and share breathing space with uninfected commuters. Upon reaching the hospital, they sit in a crowded triage center or waiting area, shedding the pathogen in large quantities while awaiting assessment. Alongside vulnerable individuals, field healthcare workers such as phlebotomists or social workers face serious risks, especially without pre-triage data. They move directly between infected households and uninfected families, often without recognizing the danger, unknowingly carrying the pathogen. Without early field-level data, standard medical response protocols often compel infected patients into densely populated areas, speeding up transmission. They aim to prevent this even when officials successfully map a transmission network. Containment depends on human compliance, which is consistently the weakest point, and outbreak response for hourly wage earners or low-income families. Complying with strict quarantine orders carries a devastating socioeconomic penalty, immediate job loss, and severe food insecurity. Housing instability, compounded by this, is a heavy psychological burden on isolated individuals, including intense community stigma, the fear of being perceived as dangerous, and the anxiety of managing symptoms alone. These converging pressures create an environment where the prescribed cure feels as destructive as the disease, faced with financial ruin and social isolation. Exposed contacts are economically incentivized to evade. Tracers often hide their symptoms or provide false histories. Public health policies that mandate strict isolation will likely fail unless they also address the significant socioeconomic penalties imposed on patients. Breaking this cycle requires shifting from reactive clinical tracking to proactive community-based detection before symptoms appear. This calls for deployable, decentralized technological interventions, especially tools. The Dr. Maya app and the Prema kiosk are designed with a key function, capturing early symptom reports directly at the household level, well before the patient tries to travel. They use simple color-coded risk recognition and multilingual education to bypass confusion and fear-driven delays that prevent people from reporting illnesses. This approach moves data collection into the community, reduces behavioral resistance, and removes delays that usually hinder public health surveillance when such technology is used. It creates an immediate early warning feedback loop. First, a user logs symptoms remotely. The system then provides localized advice on isolation and triages the patient at home. Next, this data is shared with a public health hub where officials can monitor infection clusters in real time and map outbreaks before they reach clinics. With this intelligence, health departments can coordinate safe, targeted sample collection at the patient's home, protecting field workers and preventing clinics from becoming amplification points. This hub-and-spoke model breaks the chain of transmission, keeping the patient in place while transmitting vital data to those who need it. For public health officials, the message is clear. Highly transmissible pathogens will exploit every gap in preclinical field data. This technology provides a way to protect vulnerable populations without the stigma of abandonment or the economic devastation linked to traditional isolation. The digital infrastructure for the next pandemic must be deployed immediately. Waiting for isolated clusters to appear guarantees they will grow into regional disasters. Health departments, NGOs, and hospital administrators must work together to validate and deploy the system now, creating an early warning network that safeguards communities. Scan the QR code to learn about the contribution to healthcare of Dr. Kadiali Srivatsa and call him via WhatsApp. Be the leader in literacy and public health, and be remembered as the person who implemented the system that revolutionized healthcare in the 21st century. Protect, prevent, and empower individuals to conquer fear and reclaim their free will. Let Dr. Maya AI and Prema kiosks serve as an early warning system before fear spreads faster than an infection.